Somebody struggling from substance abuse is Nyari, who is a social worker, and she's also not alone. No stranger also to detox is MANDLA, who is a medical lab scientist. He also specialized in illicit drug abuse. It's Capital 100.4 FM. Harare is happy. Let me start off by welcoming Tendai. How are you, Tendai? Thanks for coming in.
I'm good. How are you? How are you, our listeners?
Nyari, also, thank you so much for joining in.
Thank you for having me.
And lastly, but in no way least, MANDLA, how are you? It's so lovely to finally meet you. We've only ever spoken on the phone over detox. Yes. It's good to have you in studio.
No, thank you for having me.
What a pleasure. What a pleasure it is to have you. Tendai, I want to start with you because this is an important month for many people. It's Pink October, it's Breast Cancer Month. And interestingly, there seems to be a connection between cancer and addiction. Talk to us a little bit about that. From your understanding, coming from Mubatirapamwe, how does addiction link with cancer?
Right, thank you, Fulake. Addiction links with cancer in two ways. One, substance. Not only the opioid prescribed drugs for pain management, others might also fail to cope up with the news. It's more like they are grieving with the news that you now have cancer and probably it's now terminal. And for others to try to adapt to such news, they then tend to use the drugs as a way of self-medicating, coping with the stresses that are associated with a cancer diagnosis. So that's on two folds how drugs link with cancer.
And so when you have patients that have come in, has it been easy to actually communicate and possibly even educate patients, people trying to recover from addiction, the risk that they have developing cancer?
Right. When engaging with people, others, they are very, very knowledgeable and well informed, especially those that smoke cigarettes, but not the e-cigarettes. The e-cigarettes, what we call the vape, people are very, very adamant, and they are very defensive when you try to provide us such psychoeducation, telling them and informing them that these drugs, these vape, they contain dicetyl, which is also a carcinogen. People are very, very adamant. They think that these are non-harmful drugs. Then again, with alcohol, people always come with different excuses, different ways of trying to evade the conversation, that I only take ciders, I don't think it's harmful. Maybe if you go to an Atumbwa, maybe those ones are very, very harmful. But the World Health Organization have conducted a research earlier this year, and the research also revealed that it doesn't matter which type of alcohol. Even your ciders with low alcohol content, as long as there is alcohol, then you are predisposed to developing cancer, particularly in women.
Particularly in women. And so, Nyari, for you as a social worker dealing with people battling with different addictions, have you, with what Tendai is saying, how do you connect the fact that this person is battling with whatever addiction and the increased risk of that developing into a cancer? How do you connect those two? How do you link those two?
Okay. This combination is something that is very difficult. For instance, when you look at cancer on its own, imagine dealing with a client that now has the reality of the fact that he or she is going to die of cancer. Do you think trying to intervene in terms of substance use and its effect, would that client actually listen to you telling him or her, you have to stop or reduce taking opioids because they lead to addiction, something that is very difficult. And also for our clients that are abusing opioids, they know the consequences, but I think they don't understand them deeply. It's different being told that tobacco leads to lung cancer than actually seeing someone bedridden due to tobacco that has led to cancer. That exposure helps someone understand the depth of the consequences and actually motivate that individual on how to stop and then live a sober life. So more information and methods of having people you have that exposure to understand these consequences of taking opioids and all sorts of drugs on how they affect an individual, because the effects don't come out instantly. It's a lifetime thing. It's progressing. So yeah, there is really need for more information to be spread out there so that people understand how deeply they can be affected.
Yeah. Mandla, from a medical point of view, from the drugs that are most commonly used in Zimbabwe, we know marijuana is high on that list. Crystal meth is also high on that list. Cocaine is also creeping up. Which of these are we seeing more related to cancer development?
Okay, well, when you talk about things like marijuana and tobacco, these are smoked. You see, what people don't understand is what you're looking for in those drugs are psychoactive substances that give you that euphoric high, that happiness, right? But along with it, when you're burning something, there's smoke. In smoke, there are things like cyanide, there are things like carbon monoxide, and then like he was saying, there are carcinogens, mutagens, things that bind to your DNA and cause mutations and cause cancer, right? There is tar. That's how anything that you smoke, it will leave a residue in your lungs. It will irritate the entire respiratory tract from your trachea to your bronchi to your lungs, and it will leave deposits in there. So whilst your body is while your lungs are trying to clear all the tar and everything, they're working overboard. There's a lot of cell turnover. So that's what cells dividing is what leads to tumors and cancer.
Right.
So that's how you pretty much provoking your lungs to develop cancer.
Right.
You see, by making the cells continuously divide, eventually that division is dysregulated and it starts doing it on its own in the absence of a negative stimulus.
Right. So this is with tobacco, marijuana,
anything that's smoked.
That's
and then you have alcohol that you drink, and it irritates the entire GI tract. That's your mouth, esophagus, stomach, your intestines. And so you can get, there's oral cancer, cancer of the mouth, esophageal cancer of the esophagus, food pipe, gastric cancer, your stomach, intestinal cancer, and colon cancer. At the same time, the burden of metabolizing that alcohol and getting it out of the system is on the liver. That leads to your cirrhosis. You start with fatty liver, then cirrhosis, then straight up liver cancer, hepatocellular carcinoma, you see. There's also pancreatic cancer, because a lot of alcoholics get pancreatitis, you see. So, and all these drugs, they also have their metabolites, right? Because it's the liver that processes all these drugs. They come in, they go to the brain and you get the effects you're looking for. But at the same time, your body has to excrete them. They can't stay in there forever, whether you want them to or not. Often they are converted into what we call metabolites. They are modified, because these are molecules, right? These are chemical compounds that are molecules. So the liver is converting them into metabolites that are often more toxic than the drug itself. And they cause widespread damage to all sorts of organs and tissues. That's how you develop.
Yeah. It sounds like the idea of addiction is much more devastating sometimes than we care to imagine when you look at the idea of development of cancer.
Because an addict does not regulate their dosing.
Right.
Like, they're taking harmful compounds, without, they don't say, okay, I'll take this little bit. They want the effect that they want in their mind, and they'll take as much as they feel they need to get that high that they want. Not realizing that there are side effects to these compounds, that they are damaging other areas of their body while searching for that high.
Yeah. Let's talk about steroids and cancer, right? What are the common steroids we're seeing people in our country taking? I'm also asking you, Tendai, as well, if you've happened to rehabilitate people who are struggling with steroids. Is that a cause of concern for us? I'm thinking athletes, for example, people who are passionate about wellness and how they look might be taking steroids leading to addiction. Is that a cause of concern in our country?
Yes, it's a cause for concern.
It is.
For some people, steroids might become a gateway drug because someone is very particular or passionate about sports. and because of that performance enhancing effect, they were the one to keep taking them. Of course, we psychologically we start to link that with a distorted self-image and poor self-efficacy, low self-confidence, and they try to enhance that using those artificial drugs. But again, the result is always the same. It's always addiction. And for another person, it might not just end with the performance enhancement. Like Thelma always say, once you have started with one drug, it's now easier for you to get hooked to another.
Yeah. So we've understood when we're looking at cancer, and I think this is what you were speaking to, Mandla. Sorry, we'll come back to you, Nyari, just now. It is the rapid growth and multiplication of cells, right? So how do things like steroids then feed the cancer? We hear it probably will lead to things like prostate cancer.
Exactly.
How is that feeding
These steroids, for example, they're called anabolic steroids. So when you talk about metabolism, right, these are the chemical reactions happening in your body. There are some that break things down, like digestion and absorption. When you eat something, you break those molecules down so you can absorb the nutrients, right? That's catabolism. Now, anabolic steroids cause the building up reactions because they want to build up muscle mass, right? So they want more cells, bigger cells. So you're stimulating the cells to divide. And what is cancer but unregulated cell division? That's what cancer is. It's cells that shouldn't be there. That grow in an uncontrolled way, and they grow and their cell cycle is not regulated. They don't grow where they're necessary. They just grow uncontrollably.
Right.
And then they spread. That's metastasis and everything. So what they're doing, they're just a bunch of cells that are not needed, that are growing, and they're taking nutrients from everywhere in the body. They're taking oxygen, they're taking glucose. That's how they're damaging you, because they are using up what you need to survive, just so that they can grow and reach a population that is huge and just useless. That's
Nyari, earlier when you were talking about the sort of like a catch-22 situation, right? Somebody who has developed cancer, but they're also battling addiction. So from a social worker point of view, or social work point of view, how do you balance that? The support you need to give someone who is battling addiction, but now they've got a secondary situation, which is cancer, which can probably be more fatal than addiction.
Yeah, this is actually quite difficult. We would have to look at the reality of the situation. For instance, how long does the client have before they succumb to cancer? And won't the substance use actually speed up the lifetime they are left with, the lifespan they are left with? So you have to convince the client to understand that probably taking the substances will minimize the period of life they might live, the period of time they might live, and also looking at the family setup, whom he or she is staying with, because as much as he or she is struggling with the illness, there are people around that person that are also struggling with anxiety, depression, of the possibility of losing someone. So that person will have to try by all means to leave that part of substance use, and then live the life that he or she has, while the family is actually around, understanding the situation and also motivating him or her. Imagine showing your family that you have lost hope, and they are seeing all that. As much as you're going to die, they're going to be staying, they are going to be living, and they would need good memories and seeing, yes, this person struggled, but he or she tried. So you might not need to do it for yourself, but for other people around you. So that can also work as a motivation when dealing with such a client.
Mandla, Tendai was talking about how you can also develop throat cancer, right? I think it's in the family of oral cancers. You know, how then do you detect that this person, for example, is a high-risk oral cancer patient? How do you bridge those gaps?
Right. As clinical social workers, we can only make inferences from the screening results. That's why we work as a multidisciplinary team.
Right. So you actually screen for cancer?
No, we screen for substance use and determine the risk based on the responses.
Right.
Then from our inferences, we discuss the symptoms further. Then from the symptoms, then we have to read widely so that you can start to pick up some of these symptoms. My inference is that from what you described to me, these might be the symptoms of this form of cancer. So I highly suggest that you go see a physician for further screening or some tests, or maybe you might need to go for some cancer screening.
Yeah. We also appreciate, and I know none of you are doctors or oncologists, and that's fine. I'd imagine at that juncture, are you also then saying, is this benign? In other words, or it's malignant? In other words, there's a high possibility that there's a cancer there.
Right. What we do in this, we do at Not Mama observational assessment. Observational assessment by just generally looking at you, observing your non-verbal cues, observing how your body is reacting with muscle spasm and all that. But when it comes to other issues like that you are describing, or anything, our knowledge is very limited there. What way I can only describe on my report is and there is need for investigation by the medical practitioners. I cannot make inferences that this might be cancer or not. My knowledge will be limited.
Got you. It's fascinating that when somebody is an addict and they develop cancer, they then need to take opioids, which are painkillers like we've said, but they also can become an addictive substance. It's like it's a funny cycle. So Nyari, how then do you determine which patient is good to take opioids? Because if I'm already struggling with cocaine, for example, or crystal meth, let's let them use the opiate for pain management. How do you know that this one is not going to become a problem for them?
It's hard to tell. But what I can say is that when it comes to prescription medication, our medical sector, they are not doing their jobs. Opioid is addictive. That information, I didn't get it from the doctor that prescribed it or the pharmacist that gave me the medication. They didn't explain the side effects about tramadol. So imagine you are a client and you have no idea about how prescription pills can actually lead to addiction. You are now vulnerable to addiction to opioids. And then when it comes to people that are struggling with cancer and prescribed opioids, what you will need to do to avoid possible addiction is to make sure that they are monitored. Their pills, the way they are taking their pills is regulated, either by a caregiver or maybe regular checkups from the hospital. Because if you don't do that, you might think that person mentally can actually not take or abuse the pills.
But things like tramadol, like many other opioids, are over the counter. OTC.
Exactly.
And it can be very effective in terms of pain management.
Instantly. So if you are staying with someone and they have to regularly monitor, and it's a tray with 10 pills, you can't take 2 at the same time. It's supposed to be 1. But vakazoona kuti wangoine tray ine 10, but then in 2 days ausisina kana kuti in less than a week you need money probably aona wakuda kuti unotenga some pills. So just regular checkups to see kuti kana iri medical kit mapills ari kutorwa sei. Is it according to the prescription? Cannot maybe there might be some sort of addiction. Because like tramadol and ukatoitora unorara. Unorara.
Yeah, I wanted to answer your question about like cancer screening and stuff. You see how it goes is that there are signs and symptoms, right, of cancer. For example, redness, swelling, inflammation, discharges, bleeding, right? So what will happen is the social workers, like you said, will make observations and refer to a doctor. Usually the patient themselves will complain, and then they'll go to a doctor. The doctor will see, this is a general practitioner. See, this might be cancer. Then he will refer to an oncologist. From there, the oncologist will do what is called a biopsy. And they are a biopsy where you take a piece of the tissue and you send it to the lab, where a pathologist will now look at it under a microscope and see, okay, staging and grading. You know, grade 1, grade 2, stage 1, stage 2, stage 3. Is it metastasized? Is it a tumor? Or is it cancer?
But there are also a lot of times, sorry Mandla to cut you, where it's asymptomatic, right? Many people who've been diagnosed with stage 3, stage 4 cancer might not have known. They didn't present any typical redness.
Especially if it's deep, like if you know, that's why they encourage women to examine themselves for lumps. If they don't do that, they can, you know, have breast cancer that's developing rapidly and they don't know anything about it.
So because now it sounds like there needs to be a much more conjoined approach between the rehab, the social worker, but also the medical side of the development of cancer.
There are also blood tests though,
that are done.
That for asymptomatic, where the patient is not experiencing any outward visible symptoms, but there are things called tumor markers that float around in the blood. They can say, okay, this person is developing cancer that we cannot see.
Right.
That's when we, you know, go for diagnostic imaging and things like that.
Right. So even if somebody, because you were talking earlier about how if you have been an alcoholic, your liver is likely damaged. We are actually going to be doing all those tests as part of the assessment.
There is exactly a liver function test that we actually do when we admit someone, like at the International Wellness Center. When a patient comes in, we test them for drugs of abuse. We also take blood samples to assess liver function. Because, as I said, the liver is the organ that's responsible for, you know, detoxifying and eliminating drugs like alcohol and the opiates and everything. So it's the first organ that's usually in trouble in a drug abuse or a drug addict.
Got you. Yeah. One thing we've learned on Detox over the year we've been doing this show is that people who are struggling with addiction or addictive substances, right, from food, from porn, whatever, is that they are looking for a dopamine high. They're looking to experience that feel-good factor, whether it's methamphetamine, whatever it is they're taking. But we've just said opioids are actually sending signals that are cutting the pain feeling, not necessarily inducing dopamine. They do induce dopamine.
Whilst they are, because you have different kinds of painkillers, right? That's about blocking pain signals that are coming from your body.
Right.
And because it's your brain that is getting the pain signals and telling you that you're in pain and making it uncomfortable for you, making you feel that pain so that you do something about what's causing that pain. So these painkillers, they block the pain signals. But as an added effect, the opiates like codeine, morphine, tramadol, fentanyl, they give you that euphoria. It's a secondary effect. It's not meant to do that. It's kind of like a side effect. So that dopamine release, that reward, it activates the brain's reward system while also blocking the pain signals, you see.
Right.
That's what they'll be chasing. So then even when they're healed or their cancer's in remission or whatever, they have forgotten, they don't care about the pain. They now want that high, that feel-good high, that they still induce, just like marijuana, just like meth, just like alcohol. It's the same sort of reward system in the brain, that these chemicals, serotonin, dopamine, norepinephrine, things like these neurotransmitters that make you feel good.
All right. So, Tendai, as a social worker, in your experience, is it likely that a patient who is taking any opioid to manage pain will become addicted to it?
All right. That now depends. Yes, the risk is high, but that now depends with how long is the person taking those opioids, in what quantities, and how often. So imagine for someone who has been taking these prescription medication for as long as 10 years, chances are high that even if you were taking in smaller doses, we have increased tolerance. so you're likely going to develop addiction. Then for another person, they might take it for a lesser period of time, but because they were taking it in higher dosages. For example, it's your pethidine methadone.
Right, your morphine.
Yeah, exactly. A lot of people have been hooked during hospital admission.
Right.
Probably someone has been involved in accidents and they have very severe injuries, and to manage that pain, then they are prescribed such medication. And even if it's administered for short periods of time, but because of the severity of the pain, which obviously we have no instrument to measure pain, like what my colleague has always alluded to, people will now chase that high even after this pain and all those injuries have receded. We have other people now claiming to suffer from severe pain while they have been long healed.
Because they're looking for that
They
high.
are looking for
That's
that
coming
high.
from the
And
painkiller.
as a doctor, you cannot tell that someone is lying or not because they just use that scale of measuring pain. On a scale of 1 to 10, how bad is the pain that someone says they're 18 out of 10? Then obviously that perception of, oh, this pain.
So between not being able to measure the level of pain when someone is lying, from what Nyari said, that some of these painkillers are actually OTC, you just literally go to the shop and buy them. So what are the strategies do you think now we need to come up with to address substance abuse, but also the development of cancer and the misuse of these painkillers?
All right. The other one I'll just borrow from what Nyari has said. There is need for monitoring. Either a loved one, a friend, or a colleague, if they are taking prescription opioids, we need to monitor. Are they taking it within the prescribed way, or now they are overdoing it? In addition to that, there is also need for education from every clinician, from the one that prescribed it, from the one that also hands you over the counter, like Nyari also alluded to it. Yeah, so that people know. And as NGOs, as all the other healthcare providers, we have a duty and a role to also disseminate that information. Let people know that yes, we are seeking that healing. We want to manage the pain, but there are complications that we should be on the lookout for.
There are complications we should be on the lookout for as far as taking painkillers to manage pain that may result, as MANDLA has explained, in you seeking that thrill even after when you're not in pain. But more importantly, the idea that taking illicit substances can result in cancer is also equally worrying. We're discussing how then we can address both substance abuse and cancer. It's Capital 100.4 FM, Marada Zabi. How do we get a hold of you tonight?
You can get hold of me and our telehealth line 0672 379 751.
And Nyari, how do we get a hold of you?
On 0773 676 296. Calls or WhatsApp.
And I won't ask Mandla because we're coming from the same organization. It is Capital 100.4 FM, Harare Zabi. Coming up, speaking of cancer, we're going to be talking a little bit more about cancer in men. I know it's Breast Cancer Month where we normally highlight the prevalence in women. But what about men? And you get to meet a man who also has had his wife had a mastectomy because of breast cancer. We want to find out what that must be like for him.